Welcome to this OncLive News Network presentation broadcasting live from MGH Studios. Today's discussion will be focused on practical application of recent clinical data for immunotherapy in non-small cell lung cancer. I'm your host, Dr. Leora Horn, Ingram Associate Professor of Cancer Research and Clinical Director of the Thoracic Oncology Program at Vanderbilt University Medical Center in Nashville, Tennessee. Today I'm joined by two colleagues who are also experts in lung cancer research. Dr. Eddie Garon, Associate Professor of Hematology Oncology at the UCLA David Geffen School of Medicine in Los Angeles, California, and Dr. Tom Stinchcombe, Professor of Medicine at the Duke Cancer Institute in Durham, North Carolina. During the next 60 minutes, we're going to navigate through some of the questions surrounding how we treat patients with non-small cell lung cancer. We'll consider how we are currently using immuno-oncology agents, how they are sequenced with other therapies, and how the latest data will help us in making these decisions in our clinics. During the last few minutes of this broadcast, we will answer questions that have been submitted through our broadcast by members of our viewing audience. Our first segment will focus on newly diagnosed non-small cell lung cancer. We're going to discuss patients who have recently been diagnosed with metastatic disease. The first trial to consider is Keynote O3 a phase 3 trial comparing single-agent pembrolizumab to platinum-based chemotherapy in patients with advanced non-small cell lung cancer with a PD-L1 score of greater or equal than 1%. Eddie, how has this trial influenced how you're treating your patients?
So to date, it's easy because the regimen has not been approved in patients with the 1 to 49% PD-L1 expression, which is the group that is added to this from the Keynote O3 study, which did show a clear benefit in patients who have this high level of staining for PD-L1. That being said, this study is not something that I find to be very easily applicable to my patient population. It was conducted largely in places where the ability to receive a PD-1 or PD-L1 inhibitor after progression is quite limited, and in fact only about 20% of patients did cross over to receive a PD-1 or PD-L1 inhibitor. In addition, although there was a survival benefit, it was clearly driven mostly by patients who did have high-level staining for PD-L1, the group of patients for whom pembrolizumab is already approved as monotherapy. For the other patients that were part of the study, those with staining for PD-L1 between 1 and 49%, there was a hazard ratio of 0.92, so there numerically it looked a little bit better for survival, but not tremendously better, and certainly wouldn't, in my estimation, look as good as the data that we have seen for chemo-immuno combos in that patient population. So for me, the only group of patients I see this being of potential utility is that I think at academic centers where we all practice, we tend to get a group of people who are looking to be aggressive in their care. In the real world, there are many patients who forego all treatment, and there is the potential that this would take patients who might otherwise choose to forego treatment and have them be willing to undergo single-agent PD-1 inhibition for the potential of a therapeutic response.
Tom, are you doing anything different? Do you have patients who maybe come in with a PD-L1 score of 30% and absolutely refuse chemotherapy? So do you think this is something that could persuade them to consider some sort of therapy for their disease?
I think there are a few patients, but we tend to select for the patients who want to be aggressive. We also have some patients who are maybe 85, 90, and a PD-L score less than 50%. These are the mutation negative patients. I think you might be, if this is approved, be able to offer that elderly patient an option who may have concerns about toxicity with the chemo-immunotherapy combinations. But I think it's only a subset of our patients who are going to really be influenced by this trial.
So right now, first-line therapy in a greater than 1% patient, I think that's going to lead us to the next set of trials that we're going to discuss. And there has been a lot of data that's come out in the last 6 months. So maybe if we break it down by squamous and non-squamous, and when we think about patients who do not have driver mutations, so we're taking out the EGFR, the ALK, the ROS1, because we know that those patients should get targeted therapies. There have been 3 major trials that we've seen in the last 6 months in non-squamous non-small cell lung cancer. We had the Keynote trial 189 that looked at carboplatin or cisplatin pemetrexed with or without pembrolizumab. And then we had the 2 Empower trials, the trial that recently came out at World Lung looking at platinum with or without atezolizumab, And then we had the Empower trial that looked at carboplatin, paclitaxel, bevacizumab with or without atezolizumab in patients with non-squamous non-small cell lung cancer. Slightly different patient populations, but similar enough. And how are these 3 trials impacting what you're thinking about in those patients who are less than 50% positive, but also in those patients with a high PD-L1 score with non-squamous non-small cell lung cancer?
So I think for the people who are high PD-L1 greater than 50%, I still preferentially use single-agent pembrolizumab. And so to me, these trials apply more to the under 50%. And I think if we look at the 3 trials, the Empower and the Keynote 189 have overall survival benefit. The Empower 150, excuse me. Well, the Empower 132, we have progression-free survival benefit, not overall survival benefit. So when I think of these, I think the Keynote 189 showed a survival benefit in the intent to treat all PD-L1s, and I think that's a commonly used therapy in my practice. The carboplatin, paclitaxel, bevacizumab, and atezolizumab did show a survival benefit. It's like you said, it's very hard to compare patient populations in the 2 trials because bevacizumab tends to select for a better prognosis patient population. With that 4-drug combination, I do have some hesitancy related to the taxane and the bevacizumab toxicities when there's an alternative. For the carboplatin, pemetrexed, and atezolizumab, I'm going to wait for the overall survival data to make sure that that sort of shows a survival benefit. And then I think it's going to be compared to the Keynote 189 in terms of what the hazard ratios are and other aspects. And that's so I'd say most of my patients get the carboplatin, pemetrexed, and pembrolizumab combination.
Eddie, sometimes you hear people talking about these patients who are rapidly progressing and they need a quick response to therapy, especially those patients whose PD-L1 score is greater than 50%. Is there a group of patients with high PD-L1 expression that you are thinking about using the combination rather than single-agent therapy?
So it's interesting because before I had both options, I really was not very excited about the idea that there would be a group of patients where I would want to be adding the chemotherapy in. I think I thought that maybe about 10% or less. In my practice, I found it to be a little bit higher than that, of people where I really do worry as to what happens to them over the next several weeks. As you know, there are patients who somehow subjectively feel better almost immediately from this. I have a hard time even explaining that from a biologic perspective. But oftentimes, even in patients who respond, of course, it's going to take some time to see that response. And there are patients who I worry about either a delay in that response or what the consequences of a lack of efficacy would be, because there certainly are patients with PD-L1 expression that is greater than 50% who have rapid progression despite a single agent PD-1 inhibitor. So there are certainly a group of patients who seem less clinically stable that I have found a role for using both. Also, I know that there's been a lot of enthusiasm lately about cross-trial comparisons where people say, well, if you compare the O24 data to the 189 data, here's what I would do. But the reality is, if you look, the control arms do quite differently between those 2 studies. And in fact, if you wanted to use the Keynote O42 data as your comparator group, where Keynote O42 overall, even the 50% group did a little less well than what was seen in O24, then it's not as clear. So I think that in general, my practice is to look in these greater than 50% patients and give them single-agent pembrolizumab. But I am finding it creeping into my practice that there is a group that I give the chemo as well.
And what do you do for a patient when they've got toxicity? What do you stop? How do you decide? You've got a patient, they're 7 months into therapy, they've had a response, but they're coming in and they're saying, I'm tired. How do you decide? Do you stop the pemetrexed? Do you stop the pembro? Do you stop both? What drives your decisions?
I think I'd initially try and stop the pemetrexed because I think that the pembrolizumab is probably a little bit more active in this situation, going back to historical controls. I think by stopping the pemetrexed, I may alleviate the fatigue and any anemia. I guess the one exception is if I think there's an immune-related toxicity, then in that case, your hand's sort of forced to address the pembro.
The one additional thing that I'll say about that is I don't know that we are going to be the ones making that choice. I think that the patient is often going to be the one making the choice. And the promise of immunotherapy is so strong to the patients that I think they would have a hard time in most situations for us, even if we thought it might be medically reasonable, to stop the the pembrolizumab and continue with the pemetrexed, I think patients are going to have a strong desire to sort of stick with the immunotherapy approach.
That's a good point. I have patients who are hitting 2 years on their immune checkpoint inhibitors who do not want to stop. And in these studies at 2 years, patients, even on the combination therapies, were supposed to stop the therapy. And so I think that you're right. Now, there's one subset analysis in the Empower study that people talk about a lot, because what do we do with the EGFR and ALK-positive patients who technically have not responded well to checkpoint inhibitor therapy? And so in Empower 150, there was some suggestion that those patients may have benefited from the taxane, atezolizumab, bevacizumab combo. And so are you using this in patients who have progressed on their TKIs and have exhausted their TKIs, or how are you interpreting this data?
So I think from my perspective, I think it is intriguing data, and there was a progression-free survival benefit. The overall survival looked impressive, although still the confidence interval includes 1. Overall, I think that this is, to me, a somewhat appealing approach, because we also know that this is a population of patients that frankly have not done well with single-agent immunotherapy. And so I'm not that eager to hold out to give them single-agent immunotherapy later. There is this suggestion of a benefit. Also, I'm intrigued by data from the Keynote 189, which excluded EGFR and ALK patients, but where the non-smokers did appear to derive a very clear benefit from the addition of a PD-1 inhibitor. That's a little bit tempered by, I know we'll talk about the Checkmate 227 data later. There they indicated that really it would be patients who had higher mutational burden, which would be anticipated to be former smokers, patients without EGFR and ALK mutated disease. But in my own practice, it is something that I have found patients very interested in, and I have been willing to do it, either this regimen or other chemoimmunotherapy regimens that are available.
Now, you see a lot of those patients. Have you been using it? Your patients are a little more like Tennessee, where there are not as many EGFR and ALK-positive patients in your part of the world.
So I generally offer them this combination as an option, and then I've offered carboplatin and pemetrexed without the immunotherapy. And I think it's interesting to talk to the patients. I think some of them prefer the carboplatin and pemetrexed toxicity profile, but I think both are reasonable options at this point. And I think if I do use immunotherapy, it would be in the combination with the other 3 drugs. So that's really the subset that's been proven to work to date.
And there is, I guess we'll have to wait a while for that data, but there is a trial that's looking specifically in patients who progress on their EGFR inhibitor, looking at carboplatin and pemetrexed with or without pembrolizumab. So that may help us answer one of those questions. So moving from non-squamous to squamous, we've had 2 trials come out in the last 6 months. Keynote 407, which looked at carboplatin, nab-paclitaxel with or without pembrolizumab. And then we had the Empower 131 data that looked at carboplatin with a taxane paclitaxel or nab-paclitaxel with or without atezolizumab. So 2 studies, very similar patient populations. How have those trials affected how you're treating your patients with squamous cell lung cancer first line?
So I think this is another situation where we're waiting for sort of regulatory approval. That being said, there is a difference in this study, and as hesitant as I have been to look at cross-trial comparisons and in other study settings, here we have data from the Keynote 407 study that shows a progression-free survival and an overall survival benefit. From the Empower 131 study, there was a strong progression-free survival benefit, but there was not a survival benefit, and not even particularly a strong signal that in favor of survival. How that happens is a little unclear to me. I don't entirely understand why you should have such an impressive progression-free survival benefit without overall survival benefit. For me, it doesn't, sort of color much beyond that. To me, I would be inclined in this setting with regulatory approval, for instance, of both regimens, still to use the Keynote 407 data, just as Tom said, just as my preferred regimen in the EGFR mutant patients would be the one where there actually is data of a clear benefit. Here, the presence versus absence of a survival benefit between these 2 would lead me to choosing the one that has shown a survival benefit, which is the carboplatin paclitaxel, either standard paclitaxel or nab-paclitaxel plus pembrolizumab.
And maybe with time we'll get some of that survival data
Yeah.
because it definitely was an immature or interim analysis. So
Yeah.
for PFS, so maybe we will
Correct.
see some of that survival data come out with time. Are you doing anything different, Tom?
So I've actually adopted the carboplatin pembrolizumab. I think some of the insurance companies don't want to pay it, but I think really the squamous patients, it's been so stagnant in our care. And this is a trial that's been published and peer-reviewed. And I'm hopeful that this will help improve the care for those patients.
And it is an NCCN guidelines, so that does
That
make it
had
a
it.
little bit more available to our patients. Now,
Yeah.
before this data came out, I was using a lot of platinum gemcitabine in my squamous cell patients. And so sometimes I'm getting calls from the community saying, will you do this? Should I give carbo, gem, and pembro for my patients? So I have said no. I don't know if you've tried that or done anything like that.
My inclination would be say no. I mean, I think you use the combination that showed a benefit, and I think that might be.
The other thing that I would add is I've found it sort of sobering how poorly we've been able to predict where toxicity would be seen in these combinations. And so there certainly are small studies that we have seen using gemcitabine. But whether there could be a signal in a large study, I'd like to see the large study before I'd be recommending it to people.
Yeah, absolutely. And one of the unique toxicities that I think that we saw with the Keynote 189 was the nephritis, which my bias is that it's more a pemetrexed phenomenon, not necessarily the platinum agent. So yeah, we definitely have to be careful. So you brought up that hot topic of tumor mutation burden, and Checkmate 227 looked at nivolumab with or without ipilimumab, a very complicated study, almost 2,000 patients, and we've slowly seen data come out with one bite at a time. And so how are you using tumor mutation burden right now? What are your thoughts on what's being presented with Checkmate 227, and is it a regimen that you're using or excited to use in your patients with metastatic disease?
So far, we have not routinely been incorporating tumor mutation burden. One issue, we have our institutional panel for mutations, which looks at 10 mutations or gene abnormalities, including all of the 4 genomic abnormalities for which there are associated therapies. And with a panel like that, we internally do not get the data that's needed for tumor mutation burden, which will be an issue, particularly if we are in a situation where it becomes clear that this data is going to be practice changing. I think there's certainly reason for enthusiasm. I think that tumor mutation burden clearly is predicting whether or not patients will have progression-free survival. Overall survival data we're still awaiting. I think if that comes back positive, I think we are going to have to make some significant changes in terms of whether or not how we deal with the pathology specimens. Is a 10-gene panel internally going to be sufficient if we have a group of patients who are not anticipated to benefit who basically have a therapy that is driven by that will dictate their care. I think there's still some questions though, and I sort of share some of the concerns you bring up in your question, that the data's come out a little bit at a time. And in fact, this is a concern I do have. This is a very large study where oftentimes the data we're shown is based on a very small subset of that. And so I do look forward to getting a robust data set where we can really evaluate the data in its totality. What is the added benefit of the ipilimumab, for instance, which I think is still a very interesting question, and one that I still find hard to answer with the data that's available to me.
How about, do you have access to TMB? I know at our institution we do not. We also have a small 40-gene panel that's back in a few days. What are you guys doing?
So we have the same problem, that the gene panel is like 40 or 50 genes, and I think the challenge is that, one, it doesn't encompass all the targets that we want it to in the modern lung cancer world, and we don't get the TMB. I would say that I'm starting to see more patients with foundation medicine testing, which was used in the study, and we're starting to send more out to that for testing, just to try and get the TMB. I've not implemented Nivo-IPI based on the data now, and I would caution against that until we really see the overall survival benefit and updated toxicity in regards to that combination.
Hopefully we'll get more data, maybe larger data sets either at ESMO or at ASCO next year. So moving from the first line setting into patients who've progressed on therapy, now that we're using immune checkpoint inhibitors up front, what are you doing next? For a while, all that we had were single agent therapies. Are we back to single agent docetaxel with or without ramucirumab? What are you offering your patients in the second line once they progress in a checkpoint inhibitor?
I think this is one of our more difficult questions because today's successes create tomorrow's challenges. And I think, unfortunately, after the 3-drug combination of chemoimmunotherapy, the standard would be single agent docetaxel or docetaxel with ramucirumab. And I think that both of those have activity and they're sort of validated, but I think they're a little bit less appealing to some of our patients who come to academic centers, and we're trying to get a lot of these patients on trial, and that's the real focus. But I think single-agent chemotherapy would be the standard answer right now, unfortunately.
You're doing a similar...
Yeah, I've generally been using docetaxel ramucirumab in this setting. I agree with you, though. Certainly at our centers, we tend to look at a lot of clinical trials in this setting. And there is a challenge. Patients are not that enthusiastic about these approaches. And I think that in some ways it's unfortunate because I do think there'd be some benefit that they would experience by going back to a chemotherapy-based regimen, but it's been a little tough to get them that excited about it.
Now, if with the immune checkpoint inhibitors, we've heard a little bit about those patients who are rapid or hyperprogressors. And there was a subset analysis in the Ravel study. Now, granted, this was before we were using the checkpoint inhibitors, that maybe patients with less indolent disease who are more rapidly progressing, and you were the lead author and a key investigator in that study, maybe those patients had a better benefit with docetaxel and ramucirumab. Does the type of progression or where they're progressing or how quickly they progressed impact what you're doing in the second line setting?
So I think that in some of the second-line angiogenesis inhibitor studies, there has been enthusiasm about looking at people who are rapidly progressing. This is a group of patients who stands to not do well. And I think it's also important because it's a group of patients that oftentimes we'll see maybe don't get treated in a setting where we now have data in secondary analyses, for instance, from Revel that would indicate that those patients would benefit. Obviously not people whose performance status is very poor, but in people who maybe do have either they've progressed on their initial therapy or they have rapidly progressive disease, that subset does clearly benefit and appears to maintain benefits sort of on par with what was seen in the Revel study in general.
So it is something you can consider. Now, Tom, is there a time factor? So, in the second line setting, if a patient maybe got say we've got a squamous cell patient, because we know that ramucirumab, you can give it in squamous and non-squamous, and they got their taxane and then they were on maintenance pembro for 18 months and then they progress. Do you think about that patient differently than the patient who maybe progressed on like 4 or 5 months? Are you going back to a platinum doublet or how are you? There's no clinical trial. Okay. Clinical trial is always our right answer, right?
Yeah.
So there's no clinical trial. How are you approaching that patient?
So this is difficult, and I think prognostically, I think that patient's a better prognosis patient.
Yeah.
Most of the time, they have a better performance status. So I am a little bit inclined to be a little bit more aggressive in that patient, and especially. And so I think maybe the double agent docetaxel ramucirumab potentially. The patient who progresses very rapidly, I have concerns that that's a very aggressive disease, and I've taken my best shot with the 3-drug combination. I think that's the person I'm more inclined to maybe do single agent or think that we're going to have a conversation about prognosis and other things because I'm a little bit more worried about that patient. I've not gone back to a platinum doublet after an interval. That's just my practice pattern. I'm not sure if you all do that.
I think that it's, we had all our management sort of settled for a while, and then with immunotherapy, it's sort of shaken everything up. And I've tried not to go back to those decisions that we sort of made as a community before, the sort of not going back to platinum, those sorts of things. Whether that's right or wrong, of course, we don't have any data, but at least to date, I've generally not revisited those sort of 4 versus 6 cycles of platinum. Do you bring back platinum? Do you go up to 225 of the taxane? Those sorts of things. I've tried to sort of stick with where I was before this, at least so far.
Now, and not to forget, the patient who gets a first-line PD-L1 single agent, that's a very different patient. That patient should get the
Yes,
platinum.
thank you.
That's
That's an easier one.
Yeah.
What about continuing the IO therapy beyond progression? It's a question that comes up a lot for patients who come through my clinic where they're on a checkpoint inhibitor and they're slowly starting to progress, or they're progressing in 1 or 2 sites. Do you keep that IO agent going and add something? Do you stop the IO agent, switch to something different? How do you approach those patients?
In general, in my practice, I've been I think when somebody progresses on an agent, we have always said that that agent is no longer working. And I really haven't seen the data that has dissuaded me from that. The largest data set really was looking at atezolizumab in the OAK study. There they looked at patients that were continued beyond progression. I believe the response rate was about 7% in that analysis. That being said, there are all sorts of questions in my mind that come up with that. One, this is only a subset of people of patients that the practitioner felt were doing well enough to continue. So there may have been something that the practitioner said, even though they met the RECIST criteria for progression, that they, in fact, were not truly having a problem. The other thing is whether that's even a valid radiographic tool. I mean, RECIST, once you've progressed, you've progressed. And so how one can even define what a response is at that point is a little bit difficult. The other thing, again, when you do look at something like the docetaxel ramucirumab data, and this is taking a different study, I mean, the response rate there was 23%. So that's not saying that you would get 23% if you took those people that were doing well on atezolizumab and that you chose to continue, that you would get 23% in that group. But if you use that metric, that 7% is maybe not such a home run.
Mm-hmm. And one of the things I've seen in my clinic, and I don't know if you've seen it, but it's out there as well, that the patients who are on a checkpoint inhibitor and then got subsequent chemo seem to do a lot better on that subsequent chemo. I admittedly use a lower dose of docetaxel. I don't use the 75 milligrams per meter squared. I use 60. I find the 75 is hard to give. So there are options beyond progression. What do you do for the patient, Tom, who stopped and then they progressed 6 months or 8 months later? Or they were on chemo and then they progressed. Do you ever go back to an IO agent as opposed to they're on it and they're progressing, which Eddie said you stop?
So I've only had a few patients who've gone through maybe like the 2 years of pembrolizumab, and then that we observe them, and then there might be some growth. And generally, I've just started them as a fresh start. If it's a very short time after stopping the immunotherapy, I'm a little bit more skeptical and hesitant just to go back to the IO at this point. So I guess I'd summarize, I'd like to see like a 6 to 12 month treatment-free interval before going back.
And have you seen those, are they responding? Or are you seeing what we saw in Checkmate 153, where the patients who stopped at a year and then re-challenged, many of them did not re-respond?
I have to be honest, it's only a handful, and some of them I've done the carboplatin.
So it's hard to know what the response is from.
Yeah, I do this when the patient's really good performance status, asymptomatic, and it's only a handful of patients. I don't really know how to manage these situations, to be honest with you.
How about you?
Yeah. One, I must admit, I've been more aggressive about maintaining the PD-1 inhibitor probably than almost all my colleagues. I think the two inputs that go into that is that the study we were most involved in was the Keynote O3 study, and that study treated forever, and we have people who are now on to year 7 of pembrolizumab. And do those people need pembrolizumab at this point? I have no idea. We were also involved in 153. And it does give me concerns about the restarting. The one additional thing that I would say is that there, in my mind, are two different types of progression that we see on immunotherapy. One is the old traditional progression we used to see with docetaxel, where all the disease was getting worse. But we definitely see a significant percentage of patients who are progressing, and clearly progressing by RECIST data, who are really progressing at a single site. And we actually, in those situations, have been fairly aggressive about treating with radiation or radiofrequency ablation, other locally ablative approaches. And many of those patients have continued to do well for long periods of time.
And then do you continue the pembrolizumab or whatever they were on, atezo, nivo at that point?
So I've generally then continued on the patients who are on it, and interestingly, on patients who may have suffered a toxicity that led me to stop it, I've generally not resumed it, and oftentimes they do very well for long periods of time with no other problematic lesions.
I think it's really challenging because you're sort of trying to figure out, is it the disease or is it the treatment? And we're all in a very small data set, to work from individually.
Yeah, we have some of those patients. Our surgeons have also gone in and operated, and our surgeons describe, and it's also been out there in the literature, that when they operate on those patients, their lungs almost like radiation patients. Like they're very hard and they're fibrotic. But we also, depending on where they've progressed, looked at either plucking it out, but biopsying first to make sure that it's actually progression, because we've been fooled once or twice that it's granulomatous disease or other things before you immediately jump on the bandwagon of the next line of therapy. So, Tom, there are different checkpoint inhibitors that are approved. In the first line setting, right now pembrolizumab is the one that's approved, but in second line we have nivolumab, we have pembrolizumab, we have atezolizumab as monotherapy. And do you see any differences between these different drugs?
So I think the second line immunotherapy naive patient population is rapidly declining in terms of the number of patients we see, but we do still see them, and most of the time I don't think that there's a strong efficacy or a toxicity difference between the three. I often decide on schedule as the main thing, and the nivolumab can be given every 4 weeks, the pembrolizumab and the atezo every 3 weeks, and I think those are the factors more so than the differences in the data.
Yeah, I think schedule was definitely driving us. Now, are you giving nivolumab every 4 weeks? I have not. That data came from more PK/PD as opposed to the efficacy data. So I admit I've not. I'm sort of giving 6 months of every 2 weeks if I'm using it, and then going to every 4 weeks. What are you guys doing? Are you straight out every 4 weeks, no problem, when you're using it?
I am using every 4 weeks. I was very involved in the Checkmate 384 study, which actually was randomized to that question. So I'm not sure I've ever been involved in such what will probably be such useless data presentation, because in fact they now are both approved, and unless there's a huge discrepancy between the two of them, I think both of them would continue to be used. I have gone to the every 4 week. I think that when one looks at the dose range on studies to date, there's very little to indicate that there's a huge difference. And so I do have comfort with that every 4 week regimen.
I use it every 4 week, and I think some patients travel a lot. Sometimes they can be on this therapy for a long time, so it does make the patient's quality of life better. So.
Absolutely. 26 versus 13 visits a year is a dramatic difference in terms of quality of life.
Anyone who's spent much time on the 405 would like to come in less frequently to the clinic in LA rather than more.
Fair enough, and Tom has mountains to travel sometimes to get to his cancer center. So moving into earlier stage disease, every drug in oncology is first tested in the metastatic and late stage setting, and then we start seeing it creeping up into earlier and earlier stage disease to see if we can cure more patients. So we've got, in the patients who are getting concurrent chemoradiation, we've got 2 studies that are out there and have been presented at ASCO, and we also were presented at World Lung. Now, one was a large phase 3 trial, the Pacific trial, that compared durvalumab for 1 year compared to placebo in patients following concurrent chemoradiation therapy. So patients were randomized immediately after chemoradiation. And then we have the LUN 14-179 from the Hoosier Oncology Research Consortium that looked at consolidation pembrolizumab in a similar patient population. So we have a drug that's FDA approved, but pembrolizumab is out there. And so how are you using these drugs? Which drug are you using? What are you doing for patients with early stage disease?
So for the stage 3, I generally do the chemoradiation, then do the durvalumab, because that's the thing that's been proven to have a progression-free survival, overall survival benefit, and time to distant metastases. Also, the toxicity is established as well. I've not interchanged PD-1, PD-L1 inhibitors in the stage 3 setting, and I'm not prepared to do so.
And I agree. The data that we do have robust data with durvalumab in this setting. And although the Hoosier Oncology Group study is obviously an impressive study, we don't have the same regulatory approval, all of the things that go along with that. So I certainly have used durvalumab in that setting.
And hopefully that rumor is also going to start coming out monthly, and hopefully when we have that data, that'll also make it a little bit easier to give those patients. How quickly are you starting durvalumab? In the subset analysis, it said maybe if you start less than 2 weeks, there's a better survival than if you start later. Are you starting patients at 2 weeks? Are patients ready to start after 6 weeks of concurrent chemoradiation therapy?
I think this may be a discrepancy between a clinical trial population and a traditional population. I think that in fit, healthy patients that are otherwise in shape to do it in that period of time, I would. On the other hand, I am less convinced about that it's absolutely necessary, and on a practical level, there is a large chunk of our patient population where it's just not really feasible.
What happens if they're out at 7 weeks, 8 weeks? Because that trial, we had that study open. I don't know if you had the trial open at your institutions, but it was a 6 weeks hard stop from when concurrent chemoradiation finished. So what happens if someone needs a little bit of extra time? They're at 7, 8 weeks. What are you doing?
So I don't feel strong about the 14 days, but I feel the 42 weeks is 42 days or 6 weeks is. I'm pretty firm on that one. I'm not saying like 7 weeks would be bad, but I think what you're really trying to do with that is make sure that the patients tolerated the chemoradiation therapy without serious toxicity. And most of the people who are delayed have either radiation pneumonitis or bad esophagitis, and I'm somewhat hesitant to add a therapy on when they haven't recovered from the previous therapy. Is one of my concerns.
So you brought up radiation pneumonitis.
I regret that.
Yeah. So radiation pneumonitis was low in that study. So that was a nice surprise. There was not a higher incidence. Well, pneumonitis overall was low in the study, not a higher incidence. How are you sorting out for those patients who do have pneumonitis? What is the culprit? Was it you or was it your radiation oncology friend? How are you managing those patients? What are you doing?
So I think you bring a big point about the study. The patients were enrolled after chemoradiation. I think the people who had significant toxicity probably never enrolled on the Pacific trial. In clinic, we see those people and we have to manage them. I think generally the people who we start on the durvalumab and then they get pneumonitis, it can be very tricky to determine whether it's the radiation or the durvalumab. And so it can be problematic. And I did put one person on steroids, and it turned out that she had PCP pneumonia. And so I think we have to be very vigilant and not just assume it's pneumonitis in this situation, just because it's sort of new waters for us to tread in.
So definitely something that patient probably didn't get better on steroids, which led to the bronch. So something to think about. Whether it's immune-related or radiation pneumonitis, they both respond to steroids. If they don't get better, get your pulmonologist involved straight away.
Yeah, I think it helps if you have an integrated system where the pulmonologists kind of know the lung cancer patients.
Do your pulmonologist see every patient who gets pneumonitis, or do you pick and choose? Do you manage it yourself? Sort of how you're at a big center, you've got multidisciplinary care. What should a doc in the community do? Do you send every patient in, or should you see how you're doing first?
I generally try and manage it myself, and if the patient's getting symptomatically better, they sort of stay in my clinic. But if they're not improving, like that patient, then I start sending them to the pulmonologist and saying, well, maybe it's something I'm missing, or an infectious etiology that I'm not covering, and that's when I send them. I generally, 2 to 4 weeks without an improvement, that's when I start to get a little bit more nervous and try and get some more help.
So Eddie, pneumonitis is not uncommon, and if a patient does get pneumonitis, are you going to re-challenge them after that break from durvalumab?
So I think it depends on, one, obviously depends on the grade. A high-grade pneumonitis is going to be of greater concern than a lower grade. And also, some of it's going to depend on a very subjective decision about whether I think this is radiation pneumonitis that, that was just there or not. I think the reality is that oftentimes we're going to be spooked in these patients who have pneumonitis. We don't have a great marker for what pneumonitis is what, so I would generally use the same criteria that I would have used for restarting patients in the metastatic setting. Is it a low enough grade that I think it's reasonable to add it back on afterwards, with the additional sort of caveat that these patients, there are a subset of them that will have been cured. And so someone, for instance, who maybe had disease that might have been theoretically resectable, but for some reason the decision was not to resect, maybe has a better prognosis, that patient I might be less willing to restart or re-challenge with the PD-1 or with the durvalumab in this setting than I would be somebody who had bulky disease involving both supraclavicular lymph node stations as well as lymph nodes throughout the mediastinum. That person I have great confidence is likely to progress, and a re-challenge may make more sense in that setting.
Yeah, you bring out a good point, because we are going for cure in these patients, and pneumonitis can be a fairly debilitating illness that can impact quality of life. So you use the word marker, so I have to ask this question. So in Pacific, we saw some subset analysis with different markers. So when the data first came out in the EGFR positive patients, the data sort of crossed the confidence interval in terms of progression-free survival for the hazard ratio. We don't have the OS data. And then at World Lung, we saw there were maybe differences in benefit based on PD-L1 positive versus PD-L1 less than 1%, to the point where the EU has actually only approved durvalumab following concurrent chemoradiation only in patients who are PD-L1 1% or higher. What do you make of these subset analysis? They are retrospective from large trials, and is that impacting who you're giving durvalumab to right now?
Right. Well, it's sort of interesting, because at World Lung, before the data was actually presented, this was the talk over drinks that everyone would have, that in the EU they had restricted based on the 1% cut point for PD-L1, which was particularly unusual because the 1% cut point is not a defined cut point at all in the Pacific trial. The Pacific trial was designed to look at greater than 25% or less than 25%. The US FDA has been, of course, very reluctant to take sort of an unplanned subset analysis of a trial and do that sort of approach. I do think that, to me, this is a meaningful approach. One of the things that this study, one always has to remember, is this is one of the few times you were able to basically run a PD-1 or PD-L1 inhibitor versus placebo. And that was what this study was. And in this group that had no PD-L1 expression, with all the caveats of unplanned subset analysis, placebo wasn't beaten. And in fact, the survival, at least numerically, looked a little bit better in the placebo group. Would this entirely affect me? Not entirely, but there's certainly, it does give me pause that I already had on patients who I considered not particularly likely to respond to a PD-1 or PD-L1 inhibitor in the first place, patients with EGFR mutations, patients with who maybe weren't smokers and have low PD-L1 expression. So although there may be some patients who have no expression where I still would treat them, it does make me reluctant among some patients.
Do you get so at our institution, patients with early stage disease, it's kind of like don't ask, don't tell. So we don't know if they're PD-L1 positive. We don't know if they're EGFR ALK positive. Part of the rationale is if they progress to metastatic, we're going to get that information because we're going to rebiopsy and test. Do you have that information available on your patients with early stage disease at your institutions?
We do. We have tried to do that. There are a host of reasons. including a very practical one of not cutting into the slide a whole bunch of
Yeah,
times,
yeah.
into the block, excuse me, to make slides a whole bunch of times. So we generally do have that information.
Are you testing everybody?
We reflexively test for PD-L1 regardless of the stage.
Okay.
And so I think all of our patients have that. And part of it's like what Eddie said, efficiency and how to apply that information, I don't really know exactly at this point. So I think Eddie brought up a good point. We've always seen the PD-L1 in the context of other clinical factors, not always, but most of the time.
Yeah, it's hard to know. Every talk that you go to, every meeting ends, we need better biomarkers. PD-L1 was not a great predictor against docetaxel in the second line setting with nivolumab and atezolizumab. So we need the better biomarker to really figure out who that patient is. What about the patient who is not fit for chemo and just gets radiation? Are you giving them durvalumab after 6 weeks of radiation?
I am not. I think that's a different patient population from what was enrolled in the trial. And I think when you're not a candidate for chemoradiation, I think you're, for the most part, treating with a palliative intent. And I've not done durvalumab.
How about you? I haven't actually had a patient come up yet, so it hasn't.
I've been reluctant, although what I do see sometimes happening is sort of dialing down the chemo, and so
the hurdle's lowered again.
We're sort of, and we're not even doing that. Sometimes things
just
like
get
that would
one
be done
dose of
for sort of
carboplatin.
a reimbursement issue. This, I think, it's more to treat me rather than the patient, that we sort of have stuck with what the validated approach is, at least somewhat. So I think that there's no great data there. We do have studies looking at, after SBRT, for instance, looking at durvalumab, and I think those are interesting studies. So I've been reluctant, but I wouldn't say never necessarily.
So that's an interesting case you brought up. So if you started a patient on concurrent chemoradiation and you've dropped chemo halfway through, finished radiation, you would give that patient durvalumab at that point?
I would.
Yeah.
I
Okay.
think I would.
Okay.
I know when we've done it, yes, and part of it is, again, this is what the patients want.
Yes.
Now, some of those patients will go on to have pneumonitis and other problems, so it's not that it's always a great decision for the individual patient, but it's very hard after you've talked to a patient about this regimen, and they're sort of to then say, well, since we dropped, after a couple of cycles, we're also going to drop the immunotherapy you were so excited about before.
Yeah, and often you're dropping the chemo for different reasons. They're cytopenic, their counts, they're just are not there. But at least there was someone you thought could tolerate it to begin with. So what about those patients that we thought were borderline resectable and whose surgeons would say give some neoadjuvant concurrent chemoradiation and then we can assess for surgery? Has the Pacific data changed how you're managing those patients? And are your pulmonologists now biopsying more lymph nodes? It used to be that our pulmonologist would go in and just biopsy one N2 node and say it's stage 3. I'm seeing our pulmonologists are actually biopsying multiple N2 nodes. Has Pacific changed who's become a surgical candidate at your institution?
I would say maybe. So there are some clear cases in both directions. So somebody who has contralateral and mediastinal involvement, that's somebody we're not going to be sending to surgery.
Yeah,
someone who has single station, microscopic or very low burden disease, that's still somebody who I would go with a very traditional approach of going to surgery. On the other hand, we all have in our tumor boards these discussions all the time. The bulky multistation mediastinal lymphadenopathy, the patients with several lymph nodes, including a subcarinal lymph node. These poor prognostic features that have generally done quite poorly. And this is in the backdrop, of course, of the largest study ever looking at the comparison between the two, not showing a benefit. Now, I know there are subset analyses and things like that people have looked at with that. But yes, I think that whereas before I was more inclined to let the sort of surgeon duke it out with everyone else, and this sort of idea of the benefit of the doubt that the surgeon always wants there, it has made me a little more aggressive to say, in an era of chemoimmunotherapy along with radiation, that it is a reasonable treatment option, particularly in these people who I don't anticipate good surgical outcomes. But I'm interested in if that's done for either of the two of you.
We were pretty conservative that we generally took the people with a single station disease to the chemotherapy induction followed by surgical resection. We didn't do a lot of chemoradiation induction. And I think I'm fortunate to work at a place with good surgeons where we generally get median stenoscopies, and we know our single stations are really single stations. So I don't think it's changed our practice patterns, but we were pretty firm beforehand. And
our surgeons are the same, and we actually were doing more neoadjuvant chemo as opposed to concurrent chemo in those potentially surgical patients. What about a patient who gets neoadjuvant chemo, radiation, and surgery? You're giving them durvalumab, or you're saying you're done?
I'm saying that you're done.
Yeah.
I think that's a different patient population.
Yeah.
Yeah.
So speaking of surgical patients, we saw some data as well at AACR this year, and then some updates of ASCO, looking at neoadjuvant checkpoint inhibitor followed by resection. The data was published by Patrick Ford in New England Journal of Medicine, showing a nice pathological response rate in the 40 to 50% range. Where do you think this data is going? Are we ready to think about neoadjuvant immune checkpoint inhibitor or chemo immune checkpoint inhibitor for resectable patients?
I think this is the next step. I think, well, first of all, it's a small study, so I think it's a proof of concept more than a practice right now. But I think this is very appealing to me because you can get the biopsy, do the immunotherapy, then get the resection and really have a pathological assessment of the response, and it looks very promising. I think we're going to probably need some refinements into who's best for single-agent immunotherapy with the neoadjuvant approach, or who needs the chemoimmunotherapy, or who needs just to go right to surgery. Because I think some of the early-stage patients, I'm not sure if there's a lot of benefit to induction approach. It's more for the higher stage or the borderline resectable patients where we need to get that response to get them to surgery.
Are you doing anything different, Eddie?
So a lot of, in the early stage disease, we have an excellent surgeon, Jay Lee, who's the co-chair of, the co-surgical chair of the LCMC3. So we've been part of the atezolizumab study. I think for me, the big question in terms of the data, I think there's beautiful scientific data in the Ford study. The concern that I have for the long term, and studies are going to address this, is do the responses that we're seeing pathologically mean something down the road? And in the end, obviously, these are not mouse experiments. We're not trying to get rid of a tumor for the sake of having the tumor be smaller and to show a nice figure. I think that from a proof of concept, this was a tremendous work, but I think that it is going to be exciting to see in the upcoming larger studies whether or not the outcomes that we see correlate with what we really care about. Is our patients going to be living longer?
And absolutely, one of the things that I think also makes me think about these studies is they're looking at TMB, and can a surgical patient, should we be making them wait a month to get the TMB data back to get a checkpoint inhibitor? And then also, what do you do if there's not a pathological response? Do you say, okay, now we're going to give you 4 cycles of a platinum doublet just because it wasn't as good? So I think there's a lot there of what we're going to see. So that actually leads to some of the questions that are being submitted during the discussion by our audience. And a biomarker question is what came up first. What's the best biomarker for predicting sensitivity for a checkpoint inhibitor? What are you testing? What do you recommend we should tell people out in the community that should be tested? And even thinking one step forward, my question to you is what's coming? What's next beyond what is being tested now?
So, I think for me, it's a little easy, the first pass of that question, because there are only 2 approved biomarkers for these therapies, PD-L1 expression and MSI, and we don't really see MSI high much in lung. So, so that makes it easier. What I would say is that we do have fairly robust long-term survival data with PD-L1. It's probably the best single biomarker we have to date. I think the TMB we've already addressed is very intriguing. It clearly correlates with progression-free survival, but is going to have a whole host of challenges. There are a lot of very interesting scientific biomarkers, although some of them I find a little bit hard to sort of imagine. So there are things about where the T cells would be. But of course, we tend to have needle biopsies and sometimes even FNAs, which are going to make it extraordinarily difficult to make any assessment about that. The microbiome has been an area of much investigation, but are all of our patients going to be reaching into the toilet to find, to send something in? Maybe. And I think it depends on the strength of the data. So I think there's a tremendous amount of work in biomarkers. I think that it's interesting, and hopefully it will give us better biomarkers, and certainly it will give us a better scientific understanding.
And do you think it matters which PD-L1 assay you use?
We've generally used the Merck because it's the one associated with reimbursement, but I think there's, outside of the atezolizumab one that looks at the tumor cells and the infiltrating cells, there's more correlation, but I've generally just used the Merck out of simplicity.
And that's the 22C.
22C.
So a question for you, Tom. What are the options for treatment when a patient progresses after 8 months of osimertinib? And maybe I'll expand on that question. What happens if it was alectinib, or if they were ROS1 positive and on crizotinib? What are you recommending for your patients?
So I think the first step is I try and rebiopsy these patients to make sure there's not a small cell transformation or there's not a signal of what activation or mechanism of resistance is there. But assuming I don't find one that I can easily target, I think your options would be a platinum pemetrexed or carboplatin, paclitaxel, bevacizumab, and atezolizumab. I've not used single-agent immunotherapy in this patient population, in large part to Eddie's work on
Not a group of patients that does well with the single-agent therapy.
No, it is not. I guess if you prove your hypothesis disastrously wrong, you still proved something. So I guess,
Absolutely,
yeah.
absolutely. So one of the other questions that came in is something we weren't really talking about before, but what's your experience with immunotherapy in small cell lung cancer? Maybe I can answer that one.
Yeah.
So, we know right now nivolumab is approved in the third line. There are not a lot of patients with small cell who get to third line therapy. But we just had data from Empower 133 that compared carboplatin, etoposide with or without atezolizumab, and that has been our first positive study in several years with small cell lung cancer. And so there was an improvement in overall survival, although response wasn't higher. It's hard to improve on a 60 to 70% response. But hopefully when approved, I think that is a regimen that I'm going to start using in first line for stage 4 disease. Any other data that you've seen that's exciting or out there?
So I think that's the game changer in small cell, because I think we've been stuck on platinum etoposide for 20, 30 years now, and I think it does show an improvement. I think we're all interested in the Nivo-Ipi combination, although it's an NCCN, but it's not approved. That obviously has a little bit more toxicity with the double immunotherapy. And I think the single-agent nivolumab has a response rate around 10, 12%, I think. And so it's modest activity, but those responses are durable. I hope this is just the beginning of immunotherapy. There are a number of trials, maintenance trials, and other combinations that are maturing right now. And hopefully we'll get those results in the next year.
Yeah, hopefully we'll see a lot more data at ASCO next year with these drugs. Anything different that you're doing or looking forward to seeing?
No, I'm just looking forward to having approval for the addition of atezolizumab because, again, this is a place where we really haven't had advances in a long time, and I think it'll be exciting to have something different to offer than what we've had, which has obviously been associated with a good response rate, but not great long-term outcomes.
Absolutely.
Yeah.
Another question that came in, a newly diagnosed patient, are you seeing an increased use of NGS? And in cases where a single gene test must be done sequentially, what's your preferred priority that you're doing? Maybe you want to tackle that one, Eddie.
So the first one on the NGS, I don't know that I've seen lately a huge upswing right now, but I think the big question, again, is back to TMB, because you're going to need to get NGS and probably even at centralized laboratories if we're going to incorporate that into our standard practice. Again, I mentioned earlier, one issue is we don't like to keep going back into the slide, into the block to get slides, because it wastes tissue, which is, of course, very valuable for the patient's care. So we have been very reluctant to do anything that's going to be sequential testing. We want to get as much information as we can in one swoop.
And we know NCCN and other groups recognize sort of broader multiplex testing upfront, so you don't waste that time. Tom, we kind of touched on this before, durvalumab maintenance is not available. Do you substitute?
Personally, I don't substitute, nor would I use like a chemotherapy consolidation. I think we've been down that road before, and it didn't really benefit our patients, and it is associated with toxicity. So I think durvalumab is still the one and only standard of care.
So related to that chemotherapy consolidation, what do you do if a patient gets chemo-RT with weekly carbotaxol? Because a lot of people believe that you should be giving systemic doses of a platinum doublet. Where does durvalumab fit in, and what are you doing?
So I've struggled with this question too, and I historically gave the weekly chemo radiation, then the 2 cycles of carbotaxol with the understanding that there's limited benefit. But now I've been just doing the carbotaxol with radiation and quickly transitioning to durvalumab, trying to get within that 42-day window at this point.
Doing a similar thing?
Correct.
I find a lot of the patients, if you can give cystotopicide, give it. Those who got carbotaxol are often not the patients who can even tolerate carbotaxol. That actually brings us to the top of the hour. Thank you both for an excellent discussion. We hope that you found the information to be valuable for your clinical practice, and thank you for watching OncLive News Network.
Can you just look into this prompter here and smile like your picture did? 3, 2, 1. All right, now you can break.
Sorry, I totally went off script. I hope that was
No,
Oh,
good.
I thought it was
yeah,
fun.
I kept us, I mean,
kind of covered what they want.
Yeah.
yeah, you did great. I mean, I think it was better.